Yes, exactly. Our range that we've prescribed to used to be higher. Remember, it was 10, but they brought it down to 8 as the high, but we're at 6 to 8. So somewhere in there in that formula, but everybody that I talk to says you can start off low, and then if you need the volume, you can change your calculations to give additional. So, yeah. Is that good?
Is the chart on the next page going to be in the CPGs?
Yeah, I'll probably put them in there.
Okay. Well, because then you can just tell people like, hey, if you ask them how tall they are, you can look at their ideal weight.
Yeah, because at the at the end we have like abbreviations and all that. I'll put that chart in there. Yeah.
Exactly.
Yeah. I think that's.
That would be a bad idea.
Mm-hmm.
Tag it to the top of the bin and be like, here you go.
Yeah. All right. Well, good deal. All right, so here we get into a little bit on our troubleshooting. So the thing I want you to remember first is the mode. And the one that we've talked about so far is assist control, so that's AC. And so we know that the rate's at 10, but we're just kind of getting a range here, 10 to 12. And that our tidal volume they picked was 550. FiO2 we picked was 50%, and our PEEP at 5. So those are our key pieces that we're asking for when we get our orders for our event. Now, in the first two that I have here, if you notice, it says it affects O2. So your volume and your rate. So when you're dealing with CO2 issues, these are the two values that you work with, okay, to eliminate. And of course, you're going to, when you do interfacilities, because remember, we're going to use this for 911 too. But in the interfacility, sometimes these parameters are going to be off, and you're going to go, this is not normal, this is not what we were trained on, and because we've done it, and maybe they're ventilating them at, here's the deal, this is normal for adult, but all of a sudden they've got it set like at 26. And you're like, and their end tidal that you're actually seeing might be like 30. I've seen it 22, and you're like, boy, that's extreme hyperventilation. That's not good. But what happened when I made the change? And I thought, well, I'm going to correct this. I'm going to slow this rate down a little bit because, we're blowing too much off. As soon as I did, it jumped up to like the 80 to 100. And I was like, uh-oh, what's going on is this patient's being ventilated for a metabolic issue, and those settings are keeping them within somewhat of limits. So then I just took them back, because they're correlating those gases with ABGs to really see where they're at. Yeah. So you see so there's a little bit that you've got to realize. And the thing is you'll make those decisions when you do the same thing that I did. And then you'll go, let me go back, and correct that. But just remember, CO2 is right here with your rate and your tidal volume. And then when you start dealing with your O2 issues, your hypoxic patients, low O2, then you're actually going to deal with your FiO2 and your PEEP. Now, the first one, it seems it's easy for us to turn around and say, well, we only have 2 FiO2 settings on this, 60 and 100. That's it. So 60 and 100. Why? Yes, that's how yeah. That's just how they're made. This is actually an oxygen-driven device. So like some of the other ones that we were using, that you had the whole adjustment because it wasn't oxygen-driven. It actually had a means of pumping and compressing all on its own. And it could do it all at 21%. And then we can do infinite or finite adjustments up on that. Of course, we know that in the hospital settings, like ICUs like to keep this at 50% or less, for the oxidative distress and a lot of that piece and inflammation. So for us, again, for a short amount of time, hour transport, not as critical, but no, these are our limitations. Okay, 60 or 100. So if you have somebody with O2 issues, where we're not getting them saturated where we want them, it seems like it's the easiest to go to 100 on that, to unload oxygen. And then what's the PEEP do for us? It actually keeps and distends that alveoli, recruits alveoli, and allows for the gas exchange. This is what I know as the plateau. So you have peak pressure, which is actually airflow of the oxygen or the gases going in, filling all the pipes and the balloons, the lungs. And then you have the plateau, which is right where all that oxygen's there and it's crossing over during that period. That's that breath hold second or millisecond. So just remember, if we're seeing a patient and we got low sats, and then we know what we're addressing here, which is going to be FiO2 and PEEP. You might, if you have some issues with your CO2, then move into your volume and your rate. And you could blend some of that too, but keep it simple when you're dealing with derangements into that piece. Okay? Questions? Okay. So over here, we actually have your PA. This is airway pressures. And then this one here is flow. So to keep it simple, this is the flow of the gas coming out of the machine, and it's measuring just flow. It's not measuring pressure at all. It's measuring just flow, air flow. Okay. This one's actually measuring the amount of pressure that's building up within the pulmonary vault. Okay. So the first thing I want to bring your attention is if we have a PEEP of 5 or 10, this baseline, this should be down here if it's 0, but as you notice, it's above it. So this actually has a PEEP because that's how that represents. Now on the monitor, that line is thin with 0, but as we add 5, 10, or 15, that line becomes thicker. It's a black line. And over to the side, you'll actually have indicators, 0, 5, 10, 15, 20, up the side to give you the value of what your PEEP is. So it's kind of neat that when you're looking at there, you might not take your eye immediately to PEEP to see what it is, but when you look at it and you can see the baseline thick, you can automatically say, I know my patient's got PEEP. Now what is it? You could either focus on that or go look at the value that's in the box beside it. Okay, so that's kind of cool. So that's what that piece is right there. Now this part is the inspiration that we're going. So that's your peak that we're going. And a lot of times we'll play with it and we allow the lung to easily fill and close. And so if there's not a lot of pressure behind it, these tend to be lower and we can see the total volume going in and it's a nice waveform, and then you get the plateau, and then it drops down on that piece there. But sometimes I'll turn around and I'll restrict it. So as it starts to fill, I'll hold down on it. That increases pressures, and then you watch these waves shoot way up here because all of a sudden that pressure became much higher. And so that's this afternoon, you guys will get to play with that a little bit to kind of see how you can create higher pressures. And what that should do for you is help you troubleshoot the airway issue, okay? And that's part of why when we're putting you on it, we want you to experience it, especially in the CPAP with pressure support. But I also want you to be able to use the lungs to recreate stuff and then troubleshoot what caused that and ask the questions, okay? So that's this afternoon. Now, if this is our actual flow, our pressure of the airway, and this is where it's actually coming back down, then we're back down right here. Now this one here, if you actually have a patient that is in assist mode, that means they're breathing on their own, then you shouldn't, let me back up. If you have a patient that's in control mode and it's actually giving a breath without any inspiratory effort, this line will be flat, okay, because the machine's actually calculating the next breath. But if you look right here, you see a dip right there. That's actually the person attempting to take a breath. So when they do that and they breathe in, that's negative pressure, and that changes the pressure sensing, and it's a trigger. And then as soon as it does that, it gives that volume. Okay, so these are some of the readings that you'll see. So you can see this is one the machine did. This is one where they took a spontaneous breath right here. Okay. Again, the flow here, this is volume going in, and this is the exhalation phase going down in correlation to that. if I was to pick one of these two waveforms that I was going to watch, I'd be watching this one. But you can bounce around back between them if you're curious and you want to play with it one more than the other. Just remember this, out of all that being said, that PEEP can cause hypotension. So if you have a patient, when you're increasing your PEEP from 5, 10, 15, 20, you're actually putting greater positive pressure in what's normally a negative pressure vault. Because when all of us in here are breathing right now is all negative pressure, right? And that negative pressure, think of hemodynamics, what's happening to our venous blood return. He was talking about nitrates and stuff earlier, right? On the right side of the issue for cardiac. But just right now, if I'm taking a breath, that breath is actually helping what? Promote venous return to the heart and ventricular filling. So it's part of your hemodynamics. So if you actually put too much of a steady positive pressure, you can actually cause a decrease in venous blood return to the heart, which will do what to your blood pressure? Bring it down, okay? So that's definitely something that you need to keep in mind. All right. He's over there scribbling. What you got? Oh. You taking notes? All right. So peak and plateau pressures. So the peak pressure, which reflects the resistance to airflow. Okay, just remember that. Peak pressure is the resistance. So you think about conditions that could actually cause high pressures or peak pressures to change. All right, well, I'm going to tell you, here's the examples right here if you didn't think too long. Bronchial spasms can actually cause problems with peak pressures. So can secretions and mucus plugs. Probably the most common issue with peak pressure issues. And so what do? We use the dope mnemonic, and we follow through and figure out maybe it's a mucus plug, and we do some suctioning, right? And then guess what? It resolves. Woohoo! There was a case that was just the other day that's what they did, and they brought that up. It was yesterday they talked about it. So peak works. So that's what we're looking at. And then what's the plateau pressure? This is thought to reflect the pulmonary compliance. So when you think of compliance, you think of how well or how easy it is to bag your patient, right? Is it that patient that you got to use two hands to try to squeeze a bag? That's low compliance. Or is it the patient that you squeeze effortlessly and and you see good chest rise easily? That's high compliance. Okay, so just kind of remember the terms on that. So when we have low compliance, we're having resistance, which is definitely an issue. What causes that? Well, here's some right here. Pneumothoraxes can cause low compliance. Pulmonary edema, ARDS, pneumonia. These are all issues for low compliance. And this is where the gas exchange takes place. So how do we measure? Peak is what again? It's the airway flow, right? So there's our peak. And then right here, that's the plateau. That's the breath holding. And that's where the gas exchange takes place. The correlation on the flow is just this. This is inspiration. That's expiration. Put them together. Inspiration, expiration. All right. Does that make sense? Yeah. Peak and plateau. What does peak do? Resistance to airflow. Plateau? That's the point where gas exchange is taking place. That's in your compliance. That's right. Good deal. All right, so go back for a second. So what kind of patients are these? You see them right there, right? So, Respiratory distress, yeah. Or failure, right, depending on. So can you see some of these patients as you're picking up or 911 and they're real tight and you're trying to figure out, let's do it as an interfacility. You're at a facility and you're trying to put them on your vent, but your high pressure alarms are going off, and the volume that's going in is half, if that, of what you actually has it preset at. So in other words, you have it set at 5, and the volume it goes in may have only 50, maybe 75 milliliters. And then the high pressure alarm goes off, which means that peak isn't at a normal level. It's way up. It's creating a pressure really high. And so you're going, this isn't good. Are you going to be able to do something to your vent to make this patient accept the vent, or is there something else that we have to do? Yeah, there's something else you have to do. So some of the things you have to think about is medications, right? Sedation is a big one, and the type of sedation that maybe the hospital's using. So they might actually be having somebody that the compliance is low and they got them on propofol, so they're not properly sedated. They're starving in oxygen and they're trying to breathe over it, but they can't get the volume. They're blue in their face. You seen this patient? You've seen this patient before, right? So what do? You can't get them on your vent. You're trying to bag them. You got to make decisions. Do you keep them on the propofol that's obviously not working? What? Absolutely, yeah. Can you sedate them more? Can you go up? But what happens if they become hypotensive? Can the propofol work? Now they're in their 80s. That's their problem. Yeah, if they're hypotensive in that scenario, ketamine, fentanyl. In some extreme cases, you're going to talk with a physician, and maybe you're even going to consider paralyzing your patient. And in a couple of the cases, that's the direction that actually has provided success. You know, the question always comes, well, this is a 20-year COPD. What do you want me to do after we get them intubated? I mean, they're already intubated, but you're now taking the respiratory drive away from them, and that becomes a problem with diaphragmatic wasting and stuff like that. I go, I know, but they won't make it to 21 if we don't do this. If they're 20-year, I want to see them as a 21-year COPD-er. But right now, that blue-faced person that's in there with falling sats that you're trying to get me to take that's on the vent that I can't even get on my vent, you've got to start thinking of what else you can do. So ketamine, as you brought up, fentanyl, why not MAG? I mean, what are we dealing with? Is it a compliance issue where the low compliance and the lungs are too stiff, right? Or is it just sedation? Or is it a combination of both, right? So what are we doing? And that's the thing. You have to work through that. And, it just depends on what you're seeing. Sedation might be the key because they might be fighting it. But guess what? Then you do that and you still have that. What else are we doing? We should be adding things like, MAG? NEB treatments? Is that appropriate? Yesterday they were saying terbutaline and epinephrine. And I was like, okay, fine. If there's not a contraindication for that, then go for it. The point is what are we trying to do? We're trying to improve compliance, right? Because right now the compliance is low, and we want that compliance high, right? And this patient's either through improper sedation or just through the pulmonary disease that they have, we're not able to put them on our vent. So we got to work through those things. So it's not just this by itself. It's going to take medicine to make this work. So I just want you to keep that in your mindset when you actually go to get these patients. Questions?
Well, sometimes they don't know if sedation or paralytic on some of the patients. I know it automatically increases the hospital stuff.
Yeah, I know.
They're trying their hardest not to push those it don't make no difference if I'm gonna screw her up.
Well,
that patient keeps up the same way he's doing there, they're not gonna make it. They're gonna increase their hospital stay even longer.
Yeah, but the what? But hold on. So we're worried about hospital stay, but the thing that I see when we don't correct that and we take it and put it in the back of the truck and try to fix it on the way, is they arrest.
That's exactly what I thought. You got a choice. We can do it this way, or we can call flight.
Yeah.
There's no way I'm gonna be able to transport in this thing right now.
But why they don't do it? The first thing they're gonna do.
First thing they do is walk in there, ignore everything you said, and knock them down. I know it.
Yeah.
Because I called you on that one, I was like,
Yeah.
they're giving this guy 14 milligrams of Versed, and
Yeah.
trying to maintain him on propofol, and he's fighting the crap out of everything. I'm like, all right, I'm sitting over there going, all right, if I'm ground pounding this. So it's ketamine I'm going to give him, fentanyl I'm going to give him, and then if that doesn't work, I'll give him ground. Go.
Yeah.
Yeah. Yeah. I took them all in there, into the hospital with me. And then they were like, well, we're just sending them on flight. First thing they did. So we stuck there in case, because the weather was kind of iffy.
Mm-hmm.
We stayed there just in case we're going to have to walk in, knock that sucker down, load him up, and got on the bird. We helped them load on the bird, took off. I was like, this is exactly what I was trying. I was like, why are they fighting that in ICU that way?
Yeah.
It was the craziest thing I ever saw.
Yeah. Yeah. There was a.
They're probably fighting you because you ain't gonna pull a flat zip up flat.
Yeah.
Yeah. Yeah. So I think that those are the challenges. Yeah. I like it you said that. That was what I always call them, onesies. They're hot. They're very uncomfortable, and they're hot. The first thing you want to do when you're finished is get out of them, right?
On the floor, it's different places, that's
Yeah. All right, so we're back. Questions? Does what we're talking about make sense? Totally not. All right. So, but we want it to make sense. Well, yes, we're going to do that this afternoon, and we'll put some of that together. But I think the key is that I've given you a means of correcting CO2 issues and working on O2 issues, right? The two top ones are what? Rate and volume. The lower ones are FiO2 and PEEP, right? So that's one. So kind of keep that off to the side. And then you walk into this patient, which I'm giving you the worst one because then when you get the ones that are just mid-range, it's a lot easier to deal with, right? But even if you get the ones that are a little tight, a little lower on the low compliance, you got to be able to think, all right, do I need to sedate them or can I do something else to help with the compliance, right? And just think when you start doing that, medications will definitely support that and then make working the ventilator a lot easier. So that's where we're at right now. The other part is that you know what assist control is, right? You have an assist mode, which means that the patient's breathing on their own, and every time they breathe in, it triggers and gives them a pre-described volume. And that if for some reason they tire and they stop breathing, then the control side of assist control takes over and breathes for them at a preset rate. And the assist control is the default for all modes if the apnea alarm comes on. So if apnea comes on, 20 seconds later, you're in assist control. So if we're in that CPAP, remember that piece that came out where I was talking about CPAP with pressure support, and you're thinking about intubating a patient. And so you put them on CPAP, maybe CPAP or CPAP pressure support. You get that going. Pressure support's actually giving inspiratory volume to support their breathing cycle, and you're getting your medications ready. You gave them ketamine. Maybe it's made it better to where all of a sudden you're seeing your SATs and everything where they're at. And the question was, can we leave them there? And the answer is yes. If you're happy with what you're seeing and you're getting the gas exchange and your colors there and compliance is good, Okay. But once you make the decision to rock them, then, and you've got all that going on, you should be moving to the intubation. Okay. If you can't get everything else in place, such as the gas exchange, the blood pressure, then we're probably going to go into iGel, right? But thinking about this, we've got them on CPAP pressure support. We're getting ready to do that, and then all of a sudden the patient stops breathing. You're in the process of doing your thing. You hear beep, beep, beep. You look over and you see the apnea alarm flashing, and all of a sudden you look down and you see the mode change from your CPAP pressure support to assist control. What just happened? Your patient stopped breathing. All right, they stopped breathing on their own. So now the assist control is doing what? It's ventilating them at a 10 breaths a minute. So at that point, are you ready to intubate with your glide scope, your one scope? There you go. And hopefully you are, and then that becomes successful because you set everything up. The neat part about this is this becomes a really cool tool to kind of warn you or tell you when things have gone south, and it's a backup to support some of the primary things that you would do if you had somebody in the back to start bagging for them, right? So I think that, yeah. Yes. Yes, it does. Yeah, so if you're like, normal IC is about a 3 a lot of times, but so you can change it to make it where if somebody needs to take a little bit stronger of a breath before it triggers, you can do that, or you can make it more sensitive to where it's just barely doing it and giving a breath. So that's what trigger sensitivity is. So you can kind of adjust, and I want you to play with that today. Okay, so this afternoon when you come in, we're gonna be on that piece, and I want you to move the trigger and just play with it. Just take a very small breath and see if it senses the change. And if it's not enough, then change the trigger until you can get them for it to actually give you the volume. Those are the things I want you to really feel and understand, because once you have it on your face and you go through that, it'll actually kind of close the loop. It'll make sense of the muddy water. It really will. And so that's where we're just kind of doing a little bit of up front before we get into the afternoon stuff. So one of the things I'll tell you is this is synchronized intermittent mandatory ventilation. It allows the patient to breathe spontaneously. If assistance is needed, the vent will assist. If no patient effort during the trigger window, ventilator will initiate a mandatory ventilation. Kind of interesting, right? What does that sound like to you? Is that similar to assist control? In other words, it's saying what? It says that they can breathe spontaneously, and it allows it. But if there's no patient effort during the trigger window, the ventilator will initiate a mandatory ventilation. So it's kind of giving that. And so when you look at it, what are the ranges that we have? Tidal volume, 50 to 2,000. Rates, 5 to 60. We've got a calculated MV, your IE ratio, usually 1 to 4 or 3 to 1. So you can change these. You can invert your. Why would you do that? Why would you invert your? What is IE? Let's answer that question first. Inspiratory, expiratory. So which one is shorter and which one's longer? Well, if you breathe in, that's an active process, right? And that's faster. And then the passive is what? Exhalation. But if you have somebody who has a low compliance lung, that's probably not so much a passive process, is it? Because they're kind of trying to force air out, right? So would it benefit that patient to have a longer expiratory phase? In some cases, maybe. So again, we probably aren't going to recognize that in a 911 when we're setting up for intubation, but you definitely, when you get these for interfacility transfers with these critical lungs, you'll have one where maybe they invert the IE ratio or they extend the exhalation phase. But here's the deal. What if in whatever scenario, I decide to increase rate If you create the rate too fast, are you not messing with your exhalation phase? Yeah. So just something to kind of keep an eye out when you're dealing with IE ratios. Your PEEP, you can go from 4 to 20. Here's pressure support. It's off, but you can actually move to pressure. There's a trigger. It's off, but it goes from 1 to 5 liters a minute. And then termination for maximum flow is at 20 to 80%. O2